In 1949, the highest honor in medical science was awarded to a procedure that deliberately mutilated the human brain. Today, the prefrontal lobotomy is universally recognized as a barbaric error in psychiatric care. Its celebrated status in the mid-20th century represents one of the most significant deviations in the history of medicine. The 1940s lobotomy epidemic emerged from a total collapse of the American asylum system. Overcrowded and decaying 19th century facilities created a landscape of therapeutic desperation. Within these institutions, a desperate medical establishment rationalized the deliberate destruction of healthy neural tissue as a pragmatic, even compassionate triumph of behavioral management. By the 1940s, the state psychiatric hospital system was failing on a massive scale. At facilities like the Cherokee Mental Health Institute in Iowa, 1,729 profoundly ill patients were packed into wards meant for a fraction of that number. The nurses trying to manage them were subjected to grueling 14-hour shifts with almost no time off. The true scale of this neglect was forced into the national consciousness by investigative journalists like Albert Deutsch. In 1948, he published an explosive photojournalistic exposé titled The Shame of the States. Deutsch's work confronted readers with the severe material deprivation inside these crumbling facilities. In one Maryland ward captured by photographer Robert Creanish, 226 male patients were confined in a single room equipped with only 126 chairs. Dozens of men were forced to sleep on the floor or lean against peeling walls, effectively warehoused like livestock. Deutsch intended his work to spark funding and legislative reform. Instead, it triggered widespread panic among state hospital administrators. Faced with the horrifying visual reality of their own wards, these administrators began desperately searching for a rapid behavioral fix. Extreme triage suddenly seemed ethically necessary. The theoretical groundwork for that fix came from Europe. In 1935, a Portuguese neurologist named Antonio Egas Moniz theorized that severing specific neural pathways in the brain could cure severe psychoses. A year later, neurologist Walter Freeman and neurosurgeon James Watts imported Moniz's concept to the United States, performing the first standard lobotomy. By 1942, Freeman and Watts published statistics claiming a 63% clinical improvement rate, but their definition of improvement was deeply flawed. What they recorded as a psychiatric cure was actually profound emotional blunting and institutional docility. Freeman openly noted the cognitive damage, referring to his patient's post-operative state as a surgically induced childhood. The reality of this cognitive destruction was severe. In 1941, the duo performed the standard prefrontal lobotomy on 23-year-old Rosemary Kennedy. Rather than curing her behavioral issues, the surgery stripped away her ability to walk and talk, leaving her permanently incapacitated and requiring intensive care for the rest of her life. The standard lobotomy was highly destructive, but its adoption was temporarily limited by logistics. It required a sterile operating theater, an anesthesiologist, and a skilled neurosurgeon drilling burr holes into the skull. Those requirements kept the procedure contained to major hospitals. Walter Freeman, however, sought to take psychosurgery directly into the overcrowded, underfunded public wards. To do that, he had to completely eliminate the operating room and simplify the procedure. The transorbital approach targeted the thalamocortical tracts. These are dense bundles of white matter that connect the prefrontal cortex, the seat of executive function and complex thought, to the thalamus, the brain's emotional relay station. Severing these cables disconnected the emotional response from the conscious thought. To access these fibers, Freeman used a sharp metal instrument called an orbital clasp. He would lift the upper eyelid and place the tip of the spike against the paper-thin bone of the eye socket. With a quick tap of a surgical mallet, he drove the spike directly through the orbital roof and several centimeters deep into the frontal lobe. Once the instrument was embedded, Freeman performed a wide lateral sweeping motion. This blind, side-to-side arc physically sliced through the white matter. In an instant, the critical thalamocortical tracts were severed, permanently isolating the brain's emotional center. Because he was operating in basic office settings and asylum wards without anesthesiologists, Freeman engineered a workaround for sedation. He used a portable electroshock machine to induce a massive grand mal seizure, striking with the orbitoclast the moment the patient fell into a state of unconscious, flaccid paralysis. Stripped of all surgical safeguards, the procedure became incredibly fast. Prior to the transorbital method in 1946, American doctors performed about 500 lobotomies a year. By 1949, fueled by Freeman's aggressive touring and the prestige of Moniz's Nobel Prize, that number spiked tenfold to over 5,000 annual operations. Freeman operated with unchecked hubris. He personally performed 4,000 surgeries, tolerating a 14% mortality rate. Worse, his clinical indications rapidly expanded. He operated on 19 children, including a 12-year-old boy named Howard Dooley, lobotomized for $200, simply because his stepmother found his rebellions difficult to manage. Through this anatomical shortcut, a delicate theoretical procedure devolved into a brutally mass-produced instrument of institutional behavioral control. The decline of the lobotomy didn't happen because of a sudden change in ethics. It stopped because pharmacology finally provided an alternative. In the 1950s, a highly effective antipsychotic medication called chlorpromazine, marketed as Thorazine, was introduced. It functioned as a chemical lobotomy, significantly reducing psychosis and severe agitation without permanently destroying the brain's physical architecture. The impact on the bloated hospital system was immediate. This chart compares state hospital patient discharge rates before and after the drug's introduction. Following the widespread administration of Thorazine, facilities like the Colorado State Hospital recorded a 141% increase in patient discharges. The medication rapidly eased the intractable overcrowding that had plagued these asylums for decades. With the wards finally beginning to empty, the primary justification for wielding the ice pick vanished. At the same time, the cultural landscape of psychiatric care shifted. Journalists like Albert Deutsch transitioned from exposing horrors in print to testifying directly before the U.S. Senate. He demanded constitutional protections and basic rights for patients, rather than mere custodial warehousing. This movement culminated politically when President John F. Kennedy, a man intimately aware of the lobotomy's destructive cost through his own sister, signed the Community Mental Health Centers Construction Act of 1963. This landmark legislation provided federal funding for community-based care, definitively dismantling the massive state hospital system. As the institutions closed, Walter Freeman's itinerant crusade caught up with him. Frequently operating in street clothes and rejecting sterile protocols, his surgical career came to an abrupt end in 1967. While performing his third lobotomy on a patient named Helen Mortensen, he severed a blood vessel, triggering a fatal brain hemorrhage. His hospital privileges were permanently revoked. The legacy of the transorbital lobotomy remains an indelible warning. It demonstrates that therapeutic desperation and institutional pressure must never override rigorous scientific validation or the foundational mandate to do no harm.